Hello, we are going to be covering Chapter 14, and this is on therapy in Carpenter's Visualizing Psychology. All right, so we're going to start working on it through this chapter and talking about how we need to look at the factual overview of things in terms of research as well as current treatments that's available for mental illness. And as we go through the chapter, what you'll see is that modern psychotherapy actually can be quite affordable, it's humane as well as effective. It also prevents much needless suffering for a person, um, not only for people with psychological disorders, but also for those that seeking help with everyday problems with daily functioning and living. Now, of course, these are myths, and I know that in the Mythbusters, I'm having you go into the discussion board to speak about it, but here I just want you to think about it. You won't have to use the discussion board for your responses. This is more for you yourself in terms of what you think about in terms of therapy. So the first one says there is one best therapy. Now, here's the fact of things. There's so many different issues and problems, and it can be treated equally well with many different forms of therapies. And just to give you an idea, there are well over 400 type of therapeutic interventions that's out there in the world. Okay, so it's not just one best therapy. Although we do look to go and work within evidence-based treatments, we don't have to prescribe to only one significant type of paradigm. Now, I wish that I could say we can read your minds, and sometimes when you're working with an individual, that person may think that you're reading their mind, but in reality, we're not reading your mind. A good therapist really often can seem to have that uncanny ability to understand how their clients are feeling and to be able to know when someone's trying to avoid a particular situation or a particular topic. And that's not due to any kind of special mind reading ability. You know, we're not mediums. However, it's what it shows as a reflection about our training and being able to utilize our training and daily experiences working with individuals that's troubled. Now, the third one, people who go to therapists are crazy or weak. And this is one that holds a lot of people back. The fact is, most people here, they seek counseling because of the stress that's overwhelming them in their lives at that moment. Or it also could be because they realize that therapy actually can improve their functioning in the everyday situations. And it's difficult to be objective about our own problems. Think about it. When you're going through something and struggling, sometimes at that moment, it's just so unbearable, you don't think you can get through it. I got a great example. My son this evening, he calls me up and he just says, I need to talk to you. I need an ear right now. And I'm like, well, what's wrong? And he went through all the daily hassles that he was going through. And if y'all remember your stress chapter, having a few hassles a day can be all right, but when it piles up, the pressure can become overwhelming. And sometimes that's what happens for a person. He was stressed about his car breaking down. He was stressed that he was going to be having issues of getting his children to school because they've returned back to school. All kind of things, how he was going to get to work. And all these little different hassles just kept piling up for him until he became so overwhelmed that he just felt like nothing's going to be solved. So sometimes we do seek therapy, and it's not a sign that because you're trying to seek somebody who's wiser than you, but it may help you when you have a neutral party to be able to help you think things through. It helps us with our personal growth and strength because it helps us to give us insight. All right, so the next one, only the rich can afford therapy. Once upon a time, I was going to say, yes, that's definitely a true fact, but nowadays that's considered a myth as well. Therapy can be expensive, that is so true, but there are so many different clinics as well as therapists that are charging on a sliding scale, and it's based more on the client's income. And then you do have certain insurance plans that'll help cover psychological services as well. Now, the last one is if I'm taking meds, then I don't need therapy. Many people, many people feel that to be the case. But the fact is, medications like antidepressants, there is just one form of therapy. And what it does is it helps to change brain chemistry. But they can't always teach us to be able to think or behave differently. Research has suggested that the combinations of drugs and psychotherapy is more than likely going to be the best for some situation, whereas there will be other times when psychotherapy alone would be the most effective. My preference is I like to work with people and help them to resolve the situation and the problems that they have that come before them. And when it becomes so overwhelming that they're a risk to themselves or to others, that's when I might refer them to get medication uh, or use some type of psychopharmacology. All right, so according to one expert, and we're talking about from work from Kasdan, there there might be over 400, like I mentioned, different approaches when it comes to psychotherapy. So it helps for us to be able to organize it. You see here on this slide, it kind of breaks it down to give you an idea of the type of therapies um, and treatments that's going to be available. And it's been grouped in three categories, that being talk therapies, behavior therapies, as well as biomedical therapies. Now, after exploring these different approaches, we'll conclude with a discussion of the topics that's going to involve all major forms of psychotherapy. So let's start with the talk therapies. Okay, so we begin our discussion with the professional psychotherapy, looking at traditional psychoanalysis and its modern counterpart, psychodynamic therapies. By the way, my particular paradigm is within psychodynamics. That's where I've been trained at. However, that's not the only paradigm that I work from. My other theoretical orientations would be that of choice theory. So, and I'll talk more about that. But um, pretty much we'll go into looking at psychoanalysis and psychodynamic therapies. We're going to also explore humanistic and cognitive therapies. And then, although these therapies differ significantly, I mean, huge, they're often going to be grouped together as talk therapies. And that's because it's emphasizing more about communication between the therapist and the client versus looking at behavioral and biomedical therapies that I'll talk more about later. All right, so we're going to look first at psychoanalysis. And here it's a person's psyche or the mind that's being analyzed. Traditional psychoanalysis is going to be based off of Sigmund Freud's central belief that abnormal behavior is caused by an unconscious conflicts among three parts of the psyche, that being the id, the ego, and the superego. And if you read chapter 12, you already got an idea about what I'm talking about here. So anyway, during psychoanalysis, these conflicts, they're going to be brought to consciousness. The patient comes to understand the reasons for his or her behavior and then start to realize that the childhood conditions under which these conflicts have developed no longer exist. Now, once this realization, or what we really call it as insight, occurs, the conflict now can be resolved and the patient can now start to develop more adaptive behavior patterns. Unfortunately, though, according to Freud, the ego has strong defense mechanisms, and these defense mechanisms will block unconscious thoughts from coming to light. Thus, to be able to gain insight into the unconscious, the ego really has to be tricked into relaxing its guard. Let that guard down a little bit, drop that wall. And with that goal, a psychoanalyst analyst would really try to employ 5 major methods, that being first, free association. Free association pretty much is allowing a person to say whatever comes to their mind, not stopping them, just letting them go at it. Then there's dream analysis, looking into what's going on within their dreams and seeing how that unconscious content is trying to surface up into our consciousness. Then there's being able to analyze resistance. Now, there's times when you're going to interact with people who they'll put the wall up right in therapy, and it could be here's a simple example of resistance. Someone who's always coming late to the therapy sessions. We consider that a form of resistance. We also look at analyzing transference. We also look at how we would interpret everything that's going on in the therapy sessions. Now, I already gave you a brief breakdown about free association, but just to go through it again, we're going to go a little deeper into terms of the 5 psychoanalytical techniques. And so with free association, as I mentioned, is allowing a person to speak whatever they want to. According to Freud, when you let your mind wander and remove that conscious censorship that we put in place for us over our thoughts, it's a process that's allowing you to free associate. And what happens is they'll be interested in sometimes even some bizarre connections that would spring up into awareness. Now, Freud believed that the first thing to come to a patient's mind would often be an important clue to what a person's unconscious wants or trying to conceal. So having a patient or a client recline on a couch, for example, as a lot of different little cartoons or comic books would show, where you're looking up at the ceiling, pretty much is believed to be able to encourage free associations. Now, when we talk about dream analysis here, and it's briefly discussed in Chapter 5, by the way, it's where Freud felt that psychological defenses usually will be lowered during that sleep. So our forbidden desires as well as our unconscious conflicts are going to be freely expressed when we're dreaming. And even while we're dreaming, however, these feelings and conflicts, they're going to be recognized as being unacceptable, and then it'll be where it has to be disguised, and it could be disguised as images that would have more deeper symbolic meaning. Thus, according to Freud's dream theory, a therapist might interpret a dream of riding a horse or driving a car, that being a surface type description or manifest type content, as a desire for or concerned about a sexual intercourse. That be more of the hidden underlying meaning of latent type of content or material. Now, analysis of resistance. Like I mentioned, sometimes it's like even if someone's late for the therapy session, it could be a form. And usually during free association or even the dream analysis, Freud discovered that patients often show the inability or unwillingness to want to discuss or reveal these certain type of memories, thoughts, motives, or even their experiences. So another example might be a client suddenly forgetting what they were saying or completely changing the subject altogether. It's the therapist's job to be able to identify these type of forms of resistance and help patients face the issues that they're dealing with and help them to learn how to deal with them more realistically. Now, when we talk about analysis of transference, when we're having psychoanalysis, patients or clients will disclose intimate type of feelings and memories. And those relationships that's going to be between the therapist and patient might become complex and emotionally charged. So a result of that is that the patients often start applying or transfer some of those unresolved emotions and attitudes from past relationships onto the therapist. And then the therapist will use this process of transference to be able to help the patient to relive some of those painful past relationships. But it's going to be in a more safe therapeutic setting so that he or she can be able to move on to a healthier type of relationship in the future. Now, when we talk about interpretation, this is the core of psychoanalytic therapy, and it's going to be during free associations, dream analysis, when there's resistance as well as transference, that interpretation would be occurring. So the analyst is going to be listening really close and then try to find different type of patterns or those hidden conflicts that might be occurring. And then at the right time, the therapist would explain or interpret, so speaking, those underlying meanings to the client or the patient. Now, let's look at some of the major criticisms. First being limited applicability. Psychoanalysis is very time consuming and it often lasts several years, with a person having 4 to 5 sessions a week. That's how intense it can be. This form of therapy is definitely one of the more expensive ones. Additionally, critics have suggested that it only applies to a select group of highly motivated, articulated patients that has less severity in terms of disorders versus those more complex disorders like schizophrenia, for example. Now, the other criticism is that it lacks scientific credibility. According to a lot of critics, it's really difficult, if not impossible, to be able to scientifically document the major goals of psychoanalysis. Think of it. How do we prove or disprove, for that matter, the importance of unconscious conflicts or symbolic dream images? I beg to differ with many people because I am trained within psychodynamics. It can be proven, but there is subjectivity in the process. But with good training, you know how to and when to use it. So despite these criticisms, research do show that traditional psychoanalysis can be effective for those who have the time as well as the money. Now, we talked about psychoanalysis. However, in modern psychodynamic therapy, which is my training, because a psychoanalyst, their training can span 10 to 15 years before they're considered an expert in the field to be able to practice it. Not just a regular doctorate. They go through an extensive, that's a specialization, it takes a lot of work. But in modern psychodynamic therapy, treatment here is going to be more brief. The patient is going to be treated face to face instead of laying back on the couch. Uh, and the therapist will take a more directive approach rather than waiting for unconscious memories and desires to slowly be uncovered. Now, don't get me wrong, free association is still utilized to a certain extent. However, to be able to guide an individual, we'll utilize more questions that can help them to open up to become more insightful. So, additionally, contemporary psychodynamic therapists, they focus less on that unconscious or the early childhood roots of problems. And then they're more likely, we kind of look more for the conscious processes and looking at current situations and issues. Now, these refinements have been able to help make psychoanalysis shorter, more available, as well as more effective for an increasing number of people. So One of the best known humanistic therapists, when we talk about humanistic therapies, would be Carl Rogers. Okay, he helped develop an approach that helped to encourage people to actualize their potential as well as to relate to others more genuinely. His approach is more referred to as that client-centered approach or client-centered therapy. And Rogers, he kind of used the term client instead of patient because he believed that the label patient implies that one would be sick or mentally ill rather than responsible and competent. So he omits patient from his vocabulary in that sense. Now, client-centered therapy, like psychoanalysis as well as psychodynamic theories, explores thoughts as well as feelings as a way to be able to obtain insight into the causes for certain behaviors. And for Rogerian therapists, the focus really is going to be providing an accepting atmosphere as well as encouraging healthy emotional experiences. Clients are going to be more responsible for discovering their own maladaptive behaviors and not being told by someone else. All right. Imagine how you would feel when you are with someone who believes that you're a good person with unlimited potential, a person who believes that your real self is unique and valuable. Well, these are the feelings that are nurtured in humanistic therapy. We look at empathy. In empathy, we're using this technique because it has a sensitive understanding as well as sharing for another person's inner experience. Therapists here will pay attention to the body language and listen for subtle cues that's going to help them to understand the emotional experiences of their clients. To help clients to explore their feelings, the therapist will use open-ended statements such as, "You found that upsetting," or "You haven't been able to decide what to do about this," rather than asking questions or offering explanations like in some other orientations. Now, the term unconditional positive regard. This is where whatever the client's problems or behaviors are, humanistic therapists are going to offer them unconditional positive regard. This is a genuine caring for a person based on their innate value as an individual. Humanistic therapists avoids evaluative statements like, "That's good," or "You did the right thing," because such comments actually implies that the therapist is judging the client. Rogers believed that the most of us would receive conditional acceptance from our parents, our teachers, as well as co-workers or others, and that actually leads to poor self-concepts and psychological disorders. The next thing that would help in terms of our therapeutic qualities is genuineness. Humanists really believe that when therapists use genuineness and honesty and sharing their thoughts and feelings with their clients, that their clients will in turn develop self-trust as well as honest self-expression. So I like to say the term real. Genuineness to me is being real, not just to yourself, but to others. Not being afraid to disclose things about you in order for a person to make a connection to you. Then, of course, there's active listening. Using active listening involves reflecting, paraphrasing, and clarifying what the client is saying to you. The clinician in this case will communicate that he or she is genuinely interested as well as paying close attention. And you can use active listening to help improve your personal relationships. To reflect is to be able to hold a mirror up in front of a person, enabling that person to see him or herself. I always like to tell my clients that I am not here to tell them what to do, but I want to be a guide. I want to be that mirror. So I'll definitely utilize reflection as well as paraphrasing. Because to paraphrase is being able to summarize in different words, not their words, but in different words, what that person is saying. And it allows us to then go into clarification, to be able to clarify and check that both what the speaker is saying as well as what I'm listening to, that we're on the same wavelength. So supporters say that there's empirical evidence for efficacy of client-centered therapy. Now, you're gonna also have critics. Like I said, you got one side, you're gonna have the other. Okay, but critics, they will argue that outcomes like self-actualization as well as self-awareness are really going to be difficult to test scientifically. Additionally, research on specific therapeutic techniques, like when we talk about empathy and active listening, really showed mixed results. So now we'll move to cognitive therapies. Cognitive therapy assumes that faulty thought processes, and that's what I'm saying. What I'm saying is that our beliefs at that moment may be irrational, overly demanding, or it fails to be able to match reality. And this actually create problems, problem behaviors, as well as emotions. Like psychoanalysis, cognitive therapists, they believe that exploring unexamined beliefs helps to produce insight into the reasons for disturbed behaviors. However, instead of believing that a change in behavior happens because of insight, cognitive therapists actually feel that insight into negative self-talk, and that's when I say negative self-talk, I'm saying those unrealistic things that a person tells themselves. You know, you probably did it. I know I have. Um, and that this is really important. Through a process, it's called cognitive restructuring. Now, the insight allows a client to be able to challenge their thoughts, change how they interpret events, as well as modify those maladaptive behaviors they have developed. And you can see one thing I want to make mention to is on the last part of this slide, you see cognitive behavioral therapy. This has become one of the top therapeutic approaches used today. It's combining that cognitive therapy, which changes the faulty thinking or irrational thoughts, along with behavior therapy, which is helping to change those faulty behaviors. They've kind of combined it in two. So that's considered one of the most popular therapeutic approaches today. All right, but let's get back to cognitive therapy itself when we're using cognitive restructuring. Cognitive therapy teaches clients to challenge as well as change negative self-talk in order to help improve their life experiences. So one, negative interpretation and destructive self-talk, it leads to destructive and self-defeating outcomes. Secondly, positive self-talk and beliefs leads to more positive outcomes. So you can see why they would try to help change it. Imagine if you're always self-deprecating or always looking down on yourself and always talking negatively up to yourself, how well do you think you perform? One of the exercises many cognitive therapists or those who utilize CBT is having a person do affirmations of themselves daily, practicing saying things good about themselves. Because often enough, if they have devalued, feel devalued, or they're having that irrational thinking and they're self-deprecating and so forth, those faulty behaviors kind of weighs down, and then those irrational thoughts takes precedent. So how good can you feel if you're always putting yourself down? So the object is to turn it around, have you start saying good things about yourself. And right now, I got an assignment for you, not that you're going to put on paper, but you could just think about this right now. You can pause the video if you like. Can you name 5 positive attributes about yourself within 10 seconds? It's not as easy as you think. But if you can, great job. All right, I'm going to move on forward. All right, so Albert Ellis, okay, he is one of our more well-known cognitive therapists, and pretty much what he did was suggest that irrational beliefs are going to be primarily the culprit in problem emotions as well as behaviors. He proposed that most people mistakenly believe that they're unhappy or upset because of external outside events, like receiving a bad grade on an exam, which I know y'all gonna have that. Y'all gonna do hard and work hard, but that could be an example. In reality, Ellis suggested that negative emotions result from those faulty interpretations as well as irrational beliefs. And that's interpreting that the bad grade is actually going to be a sign of your incompetence and a sign that you'll never qualify for graduate school or a good job. When it can be just, again, that irrational thinking process that's pushing down on you. Now, to deal with these irrational beliefs, Ellis had developed what we call rational-emotive behavior therapy. And pretty much what happens is you treat these disorders uh, in a way where Ellis developed what we call the ABCD approach. Now, A stands for that activating event, B represents the person's belief system, C is the emotional and behavioral consequences, and D is looking at the disputing erroneous beliefs. During therapy, Ellis helped his clients identify those ABCs and then underlying their irrational beliefs by actively arguing. And I mean, when I say argue, Ellis was no joke, okay? Cajoling, as well as he teased people. I mean, he's cussed people out. He could be very blunt, to say the least. He was, because he utilized confrontational language all the time. However, once clients recognized their self-defeating thoughts, he then worked with them on how to dispute these beliefs and how to create and test out the new rational beliefs that they developed. Now, Beck, his cognitive behavior therapy, as I mentioned, is one of the top ones used today, is it's designed to reduce both self-destructive thoughts as well as that self-destructive behavior. One of the most successful applications of Beck's theory has been in the treatment actually of depression. Okay, so what Beck did was identify several thinking patterns that he believed associated with depression-prone people. First being selective perception. Here, this is focusing selectively on negative events while ignoring what's good around them, those positive events. Why am I the only person alone at this party, for example? Overgeneralization. This is when we overgeneralize and then we draw negative conclusions about one's own self-worth. I'm worthless because I failed that test. Then there's magnification. This is when we're exaggerating the importance of undesirable events or personal shortcomings, seeing them as catastrophic and unchangeable. I talked earlier about my son in his car breaking down and all the little hassles and worries that he kept building up on it. Another example you can look at would be, oh, he left me and I'll never find someone like him again. Thankfully, I don't think that way. Finally, there's the all or nothing thinking. This is when we see things as black or white, no gray in between. Okay? Uh, you could think of it not only in black and white, but like good and bad, right or wrong, being successful or being a complete failure. If I don't get straight A's, then I'll never be able to get a good job. So with Beck's cognitive behavior therapy, or you might hear people call it CBT, here clients are going to be first taught to be able to recognize and keep track of their thoughts. Usually we like to have them do some journaling. The next thing is that therapists will train with the client to help develop ways to be able to test these automatic thoughts against reality. This approach will help depressed people discover that negative attitudes are largely a product of faulty thought processes. And at this point, Beck is going to introduce the second phase of therapy. This is going to be persuading the client to actively pursue pleasurable activities. Depressed individuals often lose motivation, even for experiences they are used to find enjoyable. Simultaneously speaking, is taking on an active rather than a passive role, and then reconnecting with enjoyable experiences to help in recovering from the depression. So, cognitive therapies, they're highly effective treatments for depression, anxiety disorders, bulimia nervosa, as well as anger management, addiction, and even some symptoms of schizophrenia and insomnia. However, both Beck and Ellis, they've been criticized for ignoring or denying the client's unconscious dynamics or overemphasizing rationality, as well as minimizing the importance of the client's past. Other critics have suggested that cognitive therapies are successful because they employ behavior techniques, not because they change the underlying cognitive. So imagine that you sought treatment for depression and learn to construe events more positively and to curb your all or nothing type thinking. Further, imagine that your therapist also helped you to identify activities as well as behaviors that would promote greater fulfillment. If you found your depression lessening, would you attribute the improvements to your changing of thought patterns or change to your overt behaviors? Something to think about. Now, we have an exercise. What I like for you to do, get a paper and a pen. Um, this might wind up in your assignment again, and it might not. But for now, I like for you to go ahead and get out a paper and pen, and then I want you to take a moment to read there's 4 questions here. It's time to test your knowledge and see just how much you can recall and remember. So I'm going to give you a moment to go get that paper and pen, and then we'll get started. All right, I guess you could have paused the video at the same time, but I wanted to give you the moment. Hopefully you have had enough time. So I want you to again to look at these 4 questions. The first one is asking, what are the 4 steps of Ellis's REBT, which is Rational-Emotive Behavior Therapy? Then it's asking the second question, looking for 4 major Rogerian therapy techniques. The third question is looking at cognitive therapists, and you'll be filling in the blank in terms of assume that the problem of behaviors and emotions are caused by what? Fourth one will be Beck's 4 destructive thought patterns that's associated with depression, and being able to label the thoughts where there's 2 different scenarios that you would have to fill in the blank for. That being A, Mary left me and I'll never fall in love again. I'll always be alone. Or the second one would be, my ex-spouse is an evil monster and our entire marriage was a sham. All right, so let's go see where you're at right now. So what are those 4 steps? The ABCD of Albert Ellis's Rational-Emotive Behavior Therapy. Give you about, let's say 20 seconds or so, and then we'll look at the answers. Maybe I can play some Jeopardy music. Do, 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 do. I know. Go ahead. All right, so if you remember, A is for the activating event. That's whatever triggered the situation in the first place. You could think of what if something made you angry, or if you received a poor grade. That could be considered an activating event. Then there's B, the person's belief system. Third one is for C is the emotional and behavioral consequences of the situation. And then D is those disputing erroneous beliefs. So how did you do? Did you know the A, B, C, D of REBT? I know I sound corny, but that's okay if it helps you to remember, because REBT stands for Rational-Emotive Behavior Therapy. And yes, you do want to remember this, because yes, you'll probably have a question on the exam and you'll want to know what REBT stands for. All right, so let's go ahead and keep moving. Now, what are those 4 major Rogerian therapy techniques? Take a few seconds and jot them down, and then we'll go over them. All right, and if you need time, I recommend pausing the video until you finish. But for time's sake, I'm going to go ahead and move on. The first of the 4 would be empathy. And remember, that's that insightful awareness that helps as far as with abilities to be able to share another's inner experiences. Unconditional positive regard. That's being able to love and accept without any contingencies or judgments. Genuineness and authenticity. As I was mentioning it earlier, it's being real, being able to share yourself, and so that a client or another person for that matter realize that you're being true to them by being able to listen effectively, share effectively. And of course, when I said listening, of course, active listening was that fourth one. I gave you a hint. But remember now, with active listening, that means you're able to reflect in your own words, not the client's words. You're also paraphrasing statements as well as clarifying. Again, you want to be able to be a mirror for your client. All right, so what about how cognitive therapists assume that problem behaviors and emotions are caused by thinking? What we're talking about with cognitive therapy? What is that main aspect? What is it that clients generally show or demonstrate? All right, and in terms of going with the flow and keeping up with time, if you still need to writing it down, pause the video. Otherwise, the answer is faulty thought processes and beliefs, those irrational thoughts that one would have. All right, so we're now coming to that fourth question, Beck's 4 destructive thought patterns, which I did put them up for you to kind of help out, okay? Because there's a lot there. But remember, selective perception, and that's focusing on those negative events. Then you have overgeneralization. You have magnification, which is exaggerating those undesirables and shortcomings that we may have. And then it's that all or none thinking. And that's where we're seeing things in black and white when there's a whole lot of gray in between. And we forget that there's gray in between. So take a moment, go ahead and jot down your answers for A. which of those four would fit that one best? And then B, which of those four would fit that one better? Pause the video if you need time, because I'm going to go ahead and give you the answers. All right, so that first answer for A, we're looking at the all or none thinking. Mary left me, and I'll never, ever fall in love again. I'll always be alone. Get those keywords in there. Never. And you know that saying, never say never. But when you are saying never, you're more than likely in that all or nothing type thinking. Same holds true as far as with always. There's permanence behind that. Therefore, there's some irrational thoughts going on with it. And it's that all or none. You don't see anything in between. Second one, my ex-spouse is an evil monster, and our entire marriage was a sham. Now, where do you see that as being? Is that the selective perception? Would that be overgeneralizing? Would that be magnifying? Or is this another all or nothing type of thought? All right, if you haven't written it down, pause the video. Otherwise, here comes the answer. It's magnification. That was extremely exaggerated. You could think a little melodramatic, wouldn't you say? That would be magnification. All right, so you've gotten an idea. And of course, you may see questions that's similar to this on the exam. And you want to approach it in that same way, okay? So now let's move on to behavior therapies. Sometimes having insight to a problem really doesn't automatically solve that problem. In behavior therapy, the focus is going to really be on the behavior itself rather than on any kind of underlying type of cause. And although a person's feelings or interpretations are not disregarded, they're also not going to be emphasized. The therapist here diagnoses the problem by listing out any kind of maladaptive type behaviors. And that's when it occurs, or adaptive behaviors that are absent or missing. The therapist then will attempt to shift the balance of those two, drawing on the learning principles of classical conditioning, operant conditioning, as well as observational learning. And if you recall, you read about that in chapter 6, learning. All right, let's keep going. Now, in addition, if you did remember, because learning was a deep chapter, and hopefully you got all the rules down, and probably not, but it doesn't hurt to always refresh your mind and go back and read it again. But if you do remember, in chapter 6, when we spoke about classical conditioning, this occurs when a neutral stimulus, NS, becomes associated with an unconditioned stimulus. That would be the UCS. And that then will elicit a conditioned response, CR. Now, sometimes a classically conditioned response, like fear of driving on big bridges, that's mine. I had a wild experience. I never cared for driving on those long bridges, like when you're going to New Orleans and you have that over on I-10. Oh, that's horrible. I hate it. But I had one worse experience by driving on the Chesapeake Bay Bridge, which is actually about 10 to 15 miles in between there long. Can you imagine? Anyway, it becomes so extreme for me that I can call that a phobia. Okay? Now, in order to treat phobias like this, behavior therapists will typically use what we call systematic desensitization. And here it begins with relaxation training. That'll be followed by imagining or directing our experience. That's various versions of that feared situation while remaining deeply relaxed and in a good state of harmonious being. Okay? Now, how does relaxation train and desensitize someone? Well, if you can remember back in chapter 2, where we talked about the sympathetic and the parasympathetic nerve and the autonomic nervous system, sympathetic does what? Can you remember? No? I want you to go back and check. I'm not giving you the answer this time, but I will talk about the parasympathetic, because those parasympathetic nerves helps to control autonomic functions when we're relaxed. So that should give you a hint. But because the opposing sympathetic nerves are going to be dominant during this time, when we're feeling anxious, nervous, physiologically, it's impossible to be both relaxed and anxious at the same time. You can't do both. Our body is just not wired that way. So the key to success here would be to be able to teach yourself how to replace your fear, or how you replace your fear response with relaxation, as opposed to dealing with that fearful stimulus. And here then it explains why this, as well as other approaches, are going to often be referred to as what we say exposure therapies. The more you do something, the more easier it becomes. Or when we talk about desensitizing, I could say, being originally from New York, one of the things that I became desensitized to was hearing about crimes all the time, or muggings and so forth, because it happened so often that after a while I became desensitized to the situation, that it didn't make me cringe. I never felt as anxious anymore about it. That's not always a good thing, but that's what happened. That's what desensitizing is. Now, with modern systematic desensitization, it can be used with virtual reality technology to help you to expose clients, if you were working with a client, to fearful situations. Like me in the car going across the bridge, I can get in a simulator to practice that. And it can be done within an office, a therapist's office. So now I'm going to take you through progressive relaxation. We're going to talk about using systematic desensitization to help in terms of if you get test anxiety. I don't know about you, but I hate standardized exams. I always have. I get nervous, I start to sweat, just can't think straight because I'm worried. So this is a great way to help with those type of anxieties. So what I want you to do, though, is I want you to be able to learn how to apply this information and put it into your own lives that can be helpful to you. So now, first thing, let's shake loose. Okay, shake it loose, shake it loose. Get your body prepped for what I want you to do. Then I want you to sit comfortably. Make sure you're sitting good, okay? Because this is going to be a progressive relaxation exercise. And it's a great practice for you to do this. If you start now and keep doing it, you'll learn that you'll find that you could do it for more than just test taking, but for other aspects of your life that you might feel a little overwhelmed. So now, if you would, take a deep breath. Let's start with a deep breath, okay? And again, loosen yourself up. And I want you to think of a 10-step hierarchy, okay, of what you need to do to bring yourself into a nice, calm area that's not anxiety arousing. I want you to think of this image. Perhaps, as the slide would suggest, the day that you are taking your exam, that is actually ending with taking the exam. You start practicing now. And as you notice, I give you all practice exams for review. You can use this during that time. So anyway, I want you to start thinking about the exam, but not anxiously. Just see the paper. see the screen, whichever way you have to take it. Some of you may be not only taking online courses this semester, but you might be going in face to face as well with the online hybrid method. And if that's the case, some people might be getting anxious because of the times we're living in and dealing with COVID-19. So this is a great way to be able to de-escalate that stress. Okay? If you find yourself at any time becoming a little anxious during doing this, then start back at the beginning of just bringing yourself down. And so even if you feel anxious right before the exam, you can remind yourself, relax, you got this. You want to take a moment now to just shut your eyes, okay, and see how you would work through the process. See how you would tackle the questions. See how you'll read the question for the full value of the question. Taking in a deep breath each time. Okay? So now let's go over how you would incorporate progressive relaxation. You already should start feeling a little calmer. And again, you want to be sitting comfortably. Make sure your head's supported. Sit back. Okay? Let's take a deep breath in. Now let it out. And as you do that, let your entire body relax. You want to start releasing all the tension. Try to visualize the tension leaving your body right now. Okay? That allows you to become more relaxed. Now what I want you to do is we're going to work from the top of your body down to your toes. Okay? So what you need to do, starting with your head, and yeah, it's going to seem difficult to do, but I want you to tense the muscles that's going from your neck to your head. Then relax. Do you feel the relaxation as it came out? Take a deep breath now. Let it out. Now let's tense the muscles in our shoulders. Hold it. Take a deep breath in. And as you release the tension in your shoulders, slowly breathe out. Now go ahead and tense your muscles in your arms. Take a deep breath in. Now slowly, as you're relaxing your muscles in your arms, breathe out. Allow your body to feel the relaxation. Let's tense up our hands. Breathe in. Now as you breathe out, slowly let the tension out of your hands. This part of your body should be feeling a little downward head because you're now more relaxed. Now tense the muscles in your stomach. Go ahead and hold it. Now take a deep breath in. And as you release the tension in your stomach, breathe out. Now I want you to put tension in your legs. Hold it. Take a deep breath in. Now slowly breathe out and release the tension in your legs. Now we come down to your toes. And your feet. The toes is the best way. Go ahead and tense them up. Curl them tight. Take a deep breath in. Now as you slowly release the curl of your toes, breathe out. Usually when you do this, you can do a count to 10 to help assist you as you do this on your own. And some people, they work from the bottom up. I like to work from the top down, as I feel it brings the body down and gives it that more relaxed state. Do what's comfortable for you. Okay? You can use this not only for test anxiety, but just when you're feeling overall stress. It allows you to get yourself back into homeostasis. So now I'm going to go ahead and move on. Hopefully I put you in a relaxed state that's not going to make you sleepy at this point. All right. So in contrast though to systematic desensitization or aversion therapy, we use classical conditioning techniques to be able to create anxiety actually rather than trying to extinguish it for aversion therapy. Here, people who engage in excessive drinking, for example, they may build up a number of pleasurable type of associations with alcohol. Now, these pleasurable associations, they're not going to be always prevented. However, with aversion therapy, here what we try to do is throw in some negative associations to be able to compete with those pleasurable ones. So think about what type of pleasure people associate when they are, excuse me, my pillow is just throwing me off there, so I gotta move it. Get comfortable again, because I done got a little too tense just then sitting up. But, getting back to what I was saying, think about some pleasurable activities people put themselves in with when they're consuming alcohol. So now, what if I threw in something that's going to make your stomach turn and make you want to vomit? Well, of course, we do have that type of thing that's going to help create nausea to help get rid of the desire, and that's what we call that negative association. All right, so now in terms of operant conditioning, this is one of those techniques that's eventually going to help bring about a desired or a targeted type of behavior that's shaping, that'll provide rewards for successive type of approximations or estimates of a target behavior. Again, you should have learned that in Chapter 6, but it doesn't hurt to hear it again. One of the most successful applications of being able to shape and reinforce has been with developing language skills for kids that has autism or who've been diagnosed with autism. And pretty much first, a child would be rewarded for being able to make any sounds if they're dealing with speech issues. Later on, we would then be forming the words and helping them with sentences. And then along the way, as they complete those tasks, we reinforce it by positive reinforcement. And one example can be just giving praise for the good job they're doing. Shaping can also help people acquire social skills as well as greater assertiveness. If you're painfully shy, this is one way of working through that. I might ask you first to role play simply by saying hello to someone that you might like or find attractive. Then I may have you practice behaviors that's going to gradually help you to suggest a get together or a date. During such type of role plays, our behavior or utilizing behavior rehearsal, I would want you to be able to give feedback, and then I would want to reinforce when you're doing the good, the changes, the behaviors that's more appropriate. Now, adaptive behaviors can also be taught or increased with techniques that provide immediate reinforcement in the form of tokens. You might have heard of token economies. So, in this instance, think about it this way. Patients that's in like Mississippi State Hospital, for example, we might give them tokens to be able to exchange for rewards like food or treats or being able to watch their special TV programs or allow them time away in a private area, uh, or give them permission to go out on outings, giving them a day pass. Now, for being able to merely attend group therapy sessions, so forth like that. Later, though, we'll reward only for actual participation within the sessions itself. And then eventually what'll happen is those tokens will stop. We'll start discontinuing them. And when that patient receives reinforcement of being helped by participation in the therapy sessions, we would start to wane that down as well. Here, that's the hope is that it'll start taking on where the person's willing to do the behaviors without as much reinforcement because it's been repeated over and over again with the reinforcement. Now, when we talk about observational learning, during a modeling of type therapy, here the client might learn how to interview for a job, for example, and they do that by watching the therapist role play it out with another interviewee, for example. Here the client would then imitate what the therapist's behavior is, and then also, kind of play the same type of roles. And then over the course of several sessions, that client will start gradually becoming desensitized to the anxiety of the interview itself. So one of the things that's great for you to do is role plays. Say you're applying for grad school, you might want to see if you can get someone to, you know, role play with you and ask you questions that you think is going to be asked of you during that interview process. We utilize this within the Department of Psychology for our graduate level students who are working on their doctorate and they're about to apply for the internship process. They're about to go in and they're trying to find a location that's a good fit for them, but we have them practice doing the interview so that they can be desensitized of that level of anxiety. The more you practice, the easier it feels. We all learn many different things by observing others as well. Therapists utilizes the principle in modeling therapy in which clients would be asked to observe and imitate appropriate models as they perform those desired behaviors. So an example would also be where Albert Bandura with him and his colleagues, and this was a long time ago, back in the late 60s, but he asked clients that was afraid of snakes and had a snake phobia or arachnophobia to watch other non-phobic people how they dealt with snakes. And then after 2 hours of being exposed to that, what they found was that over 92%, jot it down, might be a test question, but over 92% of the phobic observers allowed a snake to actually crawl over their hands or on their arms or on their necks. They allowed themselves to be touched by a snake, which is amazing. And when the therapy is combined with live modeling with direct as well as gradual practice, here it's called participant modeling. This type of modeling is also involved with social skills training as well as assertiveness training. Now, you heard me give you some brief information about behavior therapies. So in evaluating behavior therapies, we've known that it's effective with various types of problems. These problems like phobias that I mentioned or obsessive compulsive disorder, in terms of the eating disorders, sexual dysfunctions, the autistic spectrum, intellectual challenges, as well as delinquency. It's been effective for all of these. But, of course, we have to look at the criticisms and critics of behavior therapy. They raise this real important question that kind of can hit two different ways. First one is generalizability. The critics, they argue that the real world patients are inconsistently reinforced and that their newly acquired behaviors actually can disappear or extinguish. So to deal with this possibility, behavior therapists actually work to gradually shape clients toward real world rewards. So if we start out with in a token economy where they might start out with a star, this might gradually go and move up into what? Money. Money's always real life situations. Now, ethics is another area that's been criticized. They've contended that unethical for one person to control another's behavior, but behaviorists, they kind of see it as an argument for rewards and punishments already control our behaviors anyway, and that behavior therapy actually helps to increase a person's freedom by allowing them to control overtly and being able to treat people or teach people how to change their own behavior themselves. So let's take a look at the biomedical therapies. Now, biomedical therapies are going to be based on the premise that problem behaviors are caused, at least in part, by the chemical imbalances that we deal with or disturbed nervous system functioning. A physician, rather than a psychologist, will prescribe biomedical therapies. But psychologists, they do work with patients receiving biomedical therapies, and they're frequently involved in research programs to help evaluate the effectiveness. And you also do have some psychologists in the field that works within psychopharmacology, and they're able to provide medications themselves without having to refer to a physician. But it's always good to consult. Anyway, here we're discussing three different aspects, though, of my biomedical therapies. That being one, the psychopharmacology. Then there's another one called electroconvulsive therapy, or ECT. And then finally, there's psychosurgery. Now, since now since the late 50s, drug companies have been developing an amazing variety of chemicals that would help treat abnormal behaviors. And there's been some cases or discoveries from psychopharmacology that have been able to help correct chemical imbalances, while in other cases, drugs really haven't been able to relieve or suppress the symptoms of psychological disturbances, even when the underlying cause was not thought to be a biological one. Okay? So, when we talk about psychiatric drugs, they're classified into four major categories, that being anti-anxiety, antipsychotic, mood stabilizers, as well as antidepressants. So how do drug treatments such as antidepressants, for example, actually work? Although we're not fully able to understand all the mechanisms that's at play, there's been several studies that suggest that antidepressants help to increase neurogenesis. And neurogenesis is that production of the new neurons. And what happens is the synaptogenesis, which is the production of new synapses, as well as being able to help it to stimulate activity in various ways of the brain. So all that kind of plays together. The best understood action of these drugs, though, have to do with correcting that imbalance in the levels of the neurotransmitters that are located in the brain. And the association of the chemical imbalance in the brain with depression would actually counteract somewhat common myths that depression is all in your head. Now, Prozac. How do we use Prozac and other SSRIs, antidepressants, to work is like this. Antidepressants will work with the neurotransmission levels that's going to be increasing the availability of serotonin or norepinephrine. Neurotransmitters that normally elevate mood as well as arousal. Now, serotonin, it works in the prefrontal cortex and the hippocampus, as well as other parts of our brain. And what that does is regulate our mood, it regulates our sleep, our appetite, among other things. It's got a lot of responsibilities. People with depression are known to have lower levels of serotonin. Now, sending neuron releases an excess of those neurotransmitters would include serotonin. And then there's some serotonin that'll lock into our receptors on the receiver neuron. But too much serotonin would then be pumped back into the ascending neuron. Now, this is what we call a reuptake, and that'll be for storage as well as reuse. So if the serotonin is reabsorbed too quickly, here there's less availability in the brain, which that can result in that depression. Now, SSRIs like Prozac, they kind of block the normal reuptake of excess serotonin, which would leave more serotonin within our molecules to help free and stimulate receptors on that receiving neuron. This increased neural transmission will then restore the normal balance of serotonin in our brain. And I think I've done a double take on this, so I'm going to keep moving on. Uh, looks like I was trying to see. Okay, yeah, it's repeating itself, so I apologize for that one. Now, let's talk about ECT, electroconvulsive therapies. Modern ECT treatments, actually, they're conducted with considerable safety precautions in place. This includes muscle relaxant drugs that would dramatically reduce any kind of muscle contractions, and medication to be able to help patients sleep through that procedure. ECT is used less often today as it was back in the past, and only generally when other treatments have actually failed. Despite a 70% improvement rate for depression, they still don't want to make that the first type of treatment or intervention, but they rather use it as a last resort. During the early years of ECT, you had patients receiving hundreds of treatments. But now today, most of them receive 12 or fewer treatments. Sometimes that electrical current is applied only to the right hemisphere of the brain, which causes less interference with verbal memories, and then the left hemisphere as far as functioning. So it kind of makes sure we don't overdo it. With modern ECT, it's primarily going to be used on patients that have severe levels of depression or who doesn't really respond to the antidepressant medications or psychotherapy. It might be utilized for someone that's having suicidal ideations because it actually works much faster than an antidepressant drug would. So again, you see the type of issues a person's dealing with will be far more severe. It's not just something that we would throw in every single day. Next one would be psychosurgery. Now, the most extreme, and this is going to be the least used for the biomedical therapy. And this is where we're doing this. Brain surgery is going to be performed to help reduce serious, debilitating type of psychological problems. Now, you might have heard of the now outmoded form of psychosurgery, which we call lobotomies. I mean, they're taking, it's the technique where it's originated way back in the 30s by a Portuguese neurologist, Munoz, who started treating uncontrollable psychosis by cutting the nerve fibers between the frontal lobe, where the association area is for monitoring and planning behaviors are found, and that of the thalamus or hypothalamus. Now, although these surgeries have been able to reduce emotional outbursts or aggressiveness, a lot of the patients still were left with permanent brain damage. So by the mid-1950s, antipsychotic drugs, they started being used. Psychosurgery actually came to a halt. Recently, though, psychiatrists have been experimenting more with a much more limited as well as more precise type of surgical procedures that would be called deep brain stimulation, or DBS. Now, here, a surgeon will drill two tiny holes in the patient's skull and then implant electrodes in the areas of the brain believed to have been associated with a specific disorder. Now, those electrodes, they'll be connected to a pacemaker that's implanted within the person's chest or within the stomach, and then sends that low voltage electricity to the problem areas of the brain. So over time, this repeated stimulation brings significant improvement in terms of diseases like Parkinson's or epilepsy for that matter. Recently, in major depression as well as other disorders, it's been considered as well. So let's talk more about drug therapy. This poses several potential problems. First one being, although drugs might relieve symptoms for people, it seldom provides a cure. Additionally, you'll have some patients that become dependent on a drug. Now, you know we're dealing with an opioid crisis. Same can hold true for some of these different psychopharmacology type treatments. We also have to look at how research, they're still learning about drugs' long-term effects as well as potential interactions. So psychiatric medications actually can cause a variety of side effects, and you need to be aware of those. And they can range from things like mild fatigue. You might have someone who's taking an antidepressant and they always feel blah. You can also have severe impairments as a side effect that can cause problems with memory as well as movement. Final problem that drug treatment can instill would be the inexpensiveness and generally fast results that would lead to overuse in some cases. So there was a report out there in terms of talking about antidepressants that's been prescribed to approximately 50% of the time for a patient, and they walks in, when they immediately walk into the psychiatrist's office, first thing they're saying, okay, we're going to get you some Prozac, we're going to get you feeling better, and nobody ever worked on why they was feeling the way they were feeling, and that feeling causing the chemical imbalance. But despite those problems associated with them, psychotherapeutic drugs have been able to lead to revolutionary changes in our mental health field. So before the use of drugs, some patients were destined to spend a lifetime living in psychiatric institutions. Today, though, many patients improve enough to be able to return to their homes and live successfully as they continue to take their medications in order to prevent a relapse. But compliance can be a difficult task depending on the disorder. We have some people who, once they start feeling better, they stop taking the medication, and sometimes that's not a good thing. So there are challenges to ECT as well as psychosurgery that's been mentioned already. We know that ECT is a controversial type of treatment, and that again is for several reasons. But the problems with ECT might be because make it obsolete thanks to how there's been repetitive transcranial magnetic stimulations, or RTMS. And what this does, it delivers a brief but really powerful electric current through a coil of wire that's going to be placed on the head. Unlike ECT though, which passes a strong electrical current directly through your brain, that RTMS coil helps to create a magnetic pull, strong magnetic pull, and that's going to be applied to certain areas of your brain. And when used to treat depression, that coil will actually be placed over the prefrontal cortex, that region of your brain that's going to help to link to deeper parts of the brain that regulates our moods. So right now, the benefits of RTMS over ECT is still uncertain, but studies have shown that there's been marked improvements for people with depression, And unlike ECT, the patients here, they experience no seizures or having any kind of memory loss. So that shows some promise. Because all forms of psychosurgery are potentially serious or fatal, uh, then there's also going to be side effects and complications. A lot of critics suggest that they should just ban that altogether. Furthermore, the consequences, they're going to be irreversible. It's not going to be where they can go back and fix it. And so it's for those reasons that psychosurgery actually is considered more experimental, and it kind of remains highly controversial type of treatments. Psychotherapy in perspective. Now, all major forms of therapy are designed to help the client in 5 specific areas. And most therapies focus on one or more of these 5 goals. And you can identify which would be of more interest to a psychoanalyst or a cognitive therapist or a behaviorist or a psychiatrist. And so you could take a look, and these are the different forms that's available. We've talked about them, so I'm not going to go over each and every one. But let's look at an eclectic approach. Now, earlier in this beginning of the lecture, I mentioned that my training has been in psychodynamics, but that I also follow choice theory. I've utilized cognitive behavioral therapy. And what that means is what we call the eclectic approach. And that's combining techniques from different theories to find what's going to be the best suited one for our clients. Again, we try not to do a cookie cutter approach. Not all therapies are meant, one specific therapy or intervention is not going to always meet uh, the benefits for every client. We try to develop treatment plans that's individualized. Okay, so here's a great question. Does therapy work? Well, after years of controlled research and through meta-analysis, and meta-analysis pretty much is one of those methods of statistically combining and then analyzing data from a lot of different studies. But we've been able to fairly see evidence that it does. One example can be that they had an early meta-analytic review that combined 25,000, almost 25,000 people, and then found that the average person who received treatment was better off than 75% of those that didn't receive any kind of treatment that was in an unrelated control. Researchers also demonstrated that short-term treatment can be as effective as long-term treatments, and that most therapies are equally as effective for various type of disorders. Interesting enough, certain specific problems, like there are some therapies that are going to be more effective than others. So when we talked about phobias and and marital problems, and it seems to be able to respond best to more behavioral therapies, whereas depression and OCD, they're significantly going to be relieved with CBT, which is accompanied also with medication. The combination of uh, cognitive behavioral therapy as well as psychotropic medication is that 1-2 punch, and it's been found to be very effective in terms of treatment. Lastly, in the recent times, empirically supported type of practices, evidence-based, has been gaining momentum and popularity because here you're able to identify which therapies have been able to show the clearest support from research for some of the different disorders. And more times than not, when I go to work with a client, and I'm doing research on what I think what type of therapies are going to be useful, I utilize those evidence-based. And when I say evidence-based, that means it's been tested. It's something that's been done several times over and shown the effectiveness for it. All right, so let's talk about how there's different therapy formats. Therapies can be described earlier. I talked about them earlier as far as face-to-face, being one-on-one. You can have therapist to client or a group. And in this particular section, we'll look more and focus more on the major types, that being group, family, as well as marital therapies, which when we treat multiple individuals simultaneously, it can be done through telehealth, electronic, uh, which it helps treat individuals utilizing things like the internet or utilizing their cell phones or smartphones, looking at through emails. We've been able to take it beyond these days. Now, group therapy, this is a multiple person type therapy. It's where they get together and work on therapeutic goals together. Okay. Typically, a group might have between 8 to 10 people meeting with a therapist, and sometimes you might have two therapists, sometimes. But they'll meet on a regular basis to be able to talk about the different problems in their lives. A variation on group therapy would be the self-help group. And unlike other group therapy approaches, a professional really doesn't guide these groups. They're simply groups of people who they get together and share common problems like NA or AA, Alcoholic Anonymous. You have single parenthood or someone dealing with cancer, a group dealing with cancer and cancer survivors. All types that can be, and it could be self-help. But um, they would meet and give each other support. There's also what we call faith-based 12-step programs like Alcohol Anonymous, Narcotics Anonymous, Spenders Anonymous for those shopaholics. Yes, we have shopaholics, y'all. These are also examples of self-help groups. Now, although group members don't get the same level of individual attention that they can get from a one-on-one type of therapy, group and self-help therapies do provide their own unique type of advantages. So when we compare them with one-on-one therapies, they're less expensive and they do provide a broader base of social support. Group members, they actually can learn from each other's mistakes. They could be able to share insights as well as their coping strategies. They can do role plays as well as for social interactions together. Therapists, though, often will refer their patients to group therapy and self-help groups to help supplement individual therapy. Research on self-help groups for alcoholism, obesity, as well as other disorders suggests that they can be very effective. And then these either that can be done alone or in addition to individual therapy. Now, with marital and family therapies, because a family or a marriage is considered a system of interdependent parts, the problem of any one unavoidably affects all the parties involved. So therapy here can actually, it helps everyone that's living in a household, for example. The line between marital or couples therapy and family therapy can really get blurred. Here, our discussion will focus on family therapy, in which the primary aim will be to kind of change in the maladaptive family interaction patterns that develops. And all members of the family would attend these therapy sessions, though at times the therapist might find that the family members need to be seen individually or in twos or threes. You might have to break them up depending on the situation. So with family therapy, it's also useful in treating a number of different disorders as well as clinical problems. And as we looked at it in terms of psychological disorders, schizophrenic patients, they're more likely to relapse if their family members express the different kind of emotions and attitudes and behaviors that involved a lot of criticism or hostility or emotional over involvement. So you can see how family therapy can help family members to modify their behavior toward the patient. Family therapy can also be more favorable in terms of setting for adolescent drug abuse. When we speak about telehealth and electronic therapy, studies have long shown that therapy outcomes improve when increased client contact. And the electronic telehealth format can actually be the easiest and most cost-effective way to be able to increase this contact, especially in times like we have right now with where we're staying at home, staying safe at home because of COVID-19. Telehealth and electronic therapy has been utilized exponentially. Now, one of the latest technological innovations for therapy would be that with our smartphones. And of course, I don't have my smartphone with me, but I do have my iPad. And we use this so easily now. We have FaceTime, and we can be able to see our clients and be able to discuss different things where they're still getting one-on-one interaction. The way we might hold Google Meet if I was doing a conference call with you in class. Again, this is going to be more cost effective and easier, and it allows us to increase our contacts. Great to use for cognitive behavioral therapy. We might also use it in terms of with chronic widespread pain, people that can't just get out. So, utilizing the smartphones, utilizing tablets, they're all different ways that we can work with a person um, and going through telehealth, or as we say today, telepsychology. All right, so now let's talk about some cultural issues in therapy, and that's real important for us to look at. The therapies described in this chapter have been based more on Western type of European as well as North American culture. Does this mean, though, that they're unique, or do our psychotherapists do some of the same things that may, be similar in therapies in other cultures? Conversely speaking, there's fundamental therapeutic differences among cultures, right? So when we're talking about cultural similarities, when we look at therapies in all cultures, we find that they have certain key features that's common. Naming some problems that people often will feel better just by knowing that other people experience, or what we can call universality. And it's where the therapist would have the experience to be able to share and discuss because they've had similar experience and knowledge. Qualities of the therapist clients would feel that the therapist would be more caring and competent and approachable if they're more aware culturally. And that's because they're going to show concern in being able to find solutions for the problems. Therapist credibility, though, among like native healers, or it could be established, credibility can be established by helping and serving as an apprentice to a reverend healer, for example. I had the uh, had an opportunity to work with uh, Alaskan natives several years ago. And I worked with the tribal council, and I worked with their school districts, and I worked with different parties outside in terms of working with some of my clients in order for me to be aware of their customs, their cultural beliefs. if I don't have a real clue about what their belief systems or worldviews are, how effective can I really be? So I need to be able to look at what similarities we might have as far as cultures, but understand that there's going to be differences and that I need to utilize those differences when I'm working with that person. I'm not going to try to force them into my box, and I'm going to try to stay within a way of understanding their particular chasm. Okay. Now, in terms of gender and therapy, within our individualistic Western culture, men and women definitely present different needs and problems to therapists every day. And one example would be if we compare men and women, um, they're going to be more comfortable and familiar with their emotions, may have fewer negative attitudes toward therapy. Women tend to demonstrate being more willing to open up, whereas men, um, historically speaking, have been taught to not open up as much. But I'm going to say that actually is starting to shift in my belief system. I find that more males are uh, becoming more comfortable in their skin, so to speak. Um, but women have been seen through research to be more likely to seek psychological help than men. Okay. Research has also identified 5 unique concerns that's going to be related to gender and psychotherapy. Okay. That's rate of diagnosis and treatment of mental disorders, looking at the different stresses that's involved with poverty, looking at the stresses that's involved with aging, how domestic violence can have a play, specifically with women. But I don't want to discount men either, because men have experienced domestic violence as well. And then just the overall multiple roles that one has. If you're a student, a parent, working, you have different hats that you wear. Those different stressors can have a great impact on and be of great concern to an individual. And it's those different things that we have to take a look at when we're working with people. All right, so this ends our chapter on therapy. Your last chapter will be on social psychology, which will be open for you, of course, beginning Monday. And please do make sure that you are reading the chapter fully. If there are any questions or concerns, please feel free to send me a message in the inbox here in Canvas. If for some reason you're not able to get into Canvas to send that message at that time, do feel free to send me an email. On that note, I will start talking to you again about social psychology.